Hello, everyone. Thank you so much for joining us tonight. My name is Lisa Faulds, and I'm the business development representative for Ascension Alexian Brothers. And we're so happy you could join us tonight. We're going to focus on something tonight that connects all of us, and that's our health. So we hope you find tonight's presentation both informative and empowering. During the presentation, we do welcome your questions, and then intermittently, I will let Dr. Hussain know that there are questions out there. So we'll get to as many as we can during the presentation, but we'll also have a question and answer session at the end of the presentation. And before we get started, I'd like to share a little bit about Dr. Hussain with you all. She is a board-certified experienced cardiologist with Ascension Medical Group of Illinois, Heart and Vascular Care. Her offices are located in Elk Grove Village, Hoffman Estates, and Schaumburg. And Dr. Hussain specializes in diagnosing all types of cardiovascular disease. She provides preventive cardiology care to manage high blood pressure and cholesterol, heart attack, and stroke risk factors. Also AFib, heart rhythm disorders, and congestive heart failure. Dr. Hussain has a clinical interest in valvular heart disease, structural heart disease procedures, hypertrophic cardiomyopathy, preventive cardiology, and women's health. And we are absolutely thrilled to have her with us today. So with that, I will turn it over to Dr. Hussain.
Thank you so much for that introduction. Very kind introduction, Lisa. Thank you to everybody that took out the time to join this today. I really, really hope that this is informative and useful to all of you. As you all know, the topic for today is his versus her heart, or her versus his heart, what everybody needs to know about heart health. So I'm going to kick this off with a few polling questions just to understand where everybody is on their thoughts on these matters. And hopefully we try to answer all of these questions as we go through the slides today. So this is my first question to all of you. Who do you think is more likely to die from heart disease, men or women, or both?
Dr. Hussein, can you see those? I'm going to share those results with everyone so everyone can see. But about 50% of the participants said that women would be more likely. And then we have 27% men and 23% said both.
Okay, great. So I think that's really helpful to hopefully we'll do some myth busting today. That brings me to my second polling question. What is the most common symptom of a heart attack in women? And our options are shortness of breath, chest pain, nausea, vomiting, or all of the above.
All right, we're at about 70% almost. All right, we're at about 70%. So I am going to end the poll here. And the majority, I will share the results. 65% said all of the above.
Okay, now this feels like MCQs from school, which is why I threw all of the above in there, but we will answer this question as well. But I'm interested, besides that, it seems more people chose nausea, vomiting, which is curious, but we'll come to that in a bit. And the last polling question I have for everybody is a part of the topic that I will address today is hormone therapy safe for the heart in men and women? So your option is either not safe, avoid it if you can, very safe, maybe even protective, safe, but use with caution, or unknown. Data is controversial. Okay, so a lot of people said unknown data is controversial. Definitely respect that option being so predominant because data has been for several years very controversial, but we have more and more information. So I will try to answer that question too. A sizable chunk also said safe, but use with caution. So I appreciate that answer too. Thank you all for that participation. And then we'll just launch into talking about all of these things. So as a primer to kind of answer that very first question we had, which was, is heart disease the most common cause of death in men, women, or both? So this is a CDC statistic from a few years ago that shows that heart disease is in fact the most common disease of death in men. It is also the most common disease of death in females. Cancer would be second ranking in both and then followed by other reasons. But as you can see, heart disease is the predominant cause of death in both men and women. So it is so important that we are actually watching our hearts and taking preventative measures to bring down this statistic a little bit, right? So the objectives of this talk today, we're going to understand how heart disease differs between women and men. We're going to learn to recognize symptoms in both. We're going to understand the specifics of hormones in the heart. and we're going to try to know what we can all do to protect our heart a little bit more. So I'm going to start off with coronary artery disease in men versus women. This is the phenomenon of blockages occurring in the heart. So in men, the most common symptom of coronary artery disease is chest pressure. In women, it is also chest pressure. This kind of answers that second question in the poll too. In men, they more often develop obstructive disease in the heart's large coronary arteries, which is what we call the heart attacks, right? Women can have that, but they can also have symptoms from the heart's smaller blood vessels called coronary microvascular dysfunction or from coronary spasm. So in addition to having the usual type of coronary artery disease, women have been found to have other forms as well. And they're more likely to have accompanying atypical symptoms. So the other symptoms that folks were choosing, shortness of breath, nausea, vomiting, sometimes dizziness, those are more common with women, but chest pressure still remains the most common cause. Now, like we said, coronary disease about equal split between men and women, and then microvascular disease, a little bit more common in women. So something that we think about when we see women that don't have major blockages, we start looking for these other things with other testing. Risk factors for coronary disease. Let's see if this is different for men versus women. So in men, they tend to develop coronary disease earlier in life. Women's risk actually rises later, more so after menopause. Diabetes and smoking cause increased risk in men. They also cause increased risk in women. And in fact, studies show that in women, they incrementally cause more cardiovascular risk compared to men. And women have some other important life stage risk factors that we don't always think about, but this is why I always inquire about your obstetric history when we see women in clinic. If you have a history of preeclampsia, gestational hypertension, gestational diabetes, premature menopause, or certain autoimmune diseases, all of these things actually increase your risk of having coronary artery disease as a woman. So things to be aware of. So while the risk factor profile is similar for women and men, individual risk differs, and it is important to consider a woman's pregnancy-related risk factors. That's our takeaway from this. Come on to heart failure, and how is that different in men and women, and how is it similar? So men tend to have weaker hearts more commonly. Women tend to have stiffer hearts. In colloquial language, what this often you will hear your doctors talking about is an ejection fraction is more likely to be reduced in men, and in women, it's more likely to be preserved. These are just mechanistic differences. That is not to say that men will exclusively have reduced EF heart failure or women will exclusively have preserved ejection fraction heart failure. It's just a predominance of one or the other type. The major symptoms that men tend to have, shortness of breath, like swelling, fatigue, exercise intolerance, difficulty laying flat, are exactly the same that women will have. So regardless of mechanism, the symptoms are actually going to be very much the same. The treatment will vary based on the mechanism, however. So just as a reminder, weaker hearts more common in men, stiffer hearts more common in women, okay? And that really plays into how your doctor is going to treat these conditions. So the takeaway is the symptoms of heart failure are often similar in both, even though the underlying cause may be different. And the importance here is that both types deserve early recognition and treatment that may differ based on what type you have. Coming on to valve disease, this is something that's very close to my heart, pun unintended. So I'll touch on this a little bit. Coming on to aortic valve disease, in men, they tend to present a little bit younger because there's a higher prevalence of congenital bicuspid aortic valve, which is a congenital disorder of the aortic valve. And when I say younger, we're talking about the 4th, 5th decade of life. So not very young, but on the younger side. And women tend to present older and have worse symptoms, more so because they're older and they're usually frailer by the time they present. And it's usually just senile degeneration of the valve. Traditional parameters are very good for detection of valve disease in men. They're not great in women sometimes just because of smaller body size. Disease severity can be underestimated often. So now and more, we try to pay attention to this fact, and we do our measurements taking into account women's body mass index and their body surface area so that we're not missing these patients who are symptomatic from aortic valve disease but don't quite meet the traditional parameters. In the past, this led to late referrals, but now we're, every day doing a better job about this. Mitral valve disease, how's that different between men and women? In men, we're more commonly seeing degenerative disease, and these actually present later in life. Women are a little bit more prone to other conditions, mitral valve prolapse, rheumatic heart disease, mitral annular calcification, and so we actually see more mitral disease in women. The thresholds for severity are, once again, very much appropriate for men, but in women, we struggle again because of body size. And something to keep in mind for pregnant women who have ever gotten a diagnosis of mitral stenosis, typically rheumatic mitral stenosis, this can actually get worse in pregnancy, but we can successfully treat this with medications and procedures. So something to keep in mind. It is something that can get worse in pregnancy if you have the diagnosis, but it can very well be treated. Okay, so the takeaway from here is valve disease occurs in both women and men because symptoms, anatomy, and body size can differ. Evaluation and treatment are tailored to the individual. So this brings me on to the next part of this, which is hormones in the heart. This, I feel, is something that we all hear about a lot. A lot of people are curious about it. A lot of people really feel like they need hormonal therapy, but they're not sure, or they've spoken to their doctor and everybody exercises caution and says the data is murky, which is what a lot of you all answered as well. And truth be told, it is only in the past few years that we have a little bit more clarity on how hormonal therapy in general should work for people and what its effect on the heart is and how it interplays with heart health and people with heart disease. We'll try to answer that for both men and women today, okay? So hormones in the heart in women. So the first thing is this a myth or a fact? It is, in fact, not a myth. Estrogen can be protective. Can is the key word here. Can be protective for the heart before menopause. And the reason I say can and I don't say is because if you have other risk factors, for example, all of the things that we outlined, autoimmune conditions, gestational hypertension, preeclampsia, those things will rack up against you and the protective effect of estrogen kind of goes away. So the value here to understand is in the absence of any other risk factors, in the absence of things like strong family history, there is a certain level of protective effect for women before menopause. Hormone replacement therapy is not recommended to prevent heart disease. So far, the consensus on this remains. There was a time long, long ago where folks believed that because estrogen is protective before menopause, it probably is after, so we should give people hormone therapy so their hearts are healthy. That is found to be not true. Because of the way the body changes after menopause, because of the way our receptors change, we start to rack up more of the side effects of hormone therapy in terms of heart-related issues. So we're not talking about good protection anymore, like with natural estrogen. So we don't
You have a question, Dr. Hussain.
Yes.
If a woman had preeclampsia or high blood pressure during pregnancy, what does that reveal about her future risk of heart failure, heart attack, and stroke?
It tells us that they are at a higher risk than the general population. One of the things that I tell to women that have gestational hypertension is it is very important after your peripartum period, after your first few months of post-delivery, that somebody is keeping an eye on your blood pressure very, very closely. Because at that point, you become a young person that's been diagnosed with hypertension, and the effect of that can rack up over a very long period of time. So you, compared to somebody who develops hypertension later in life, you already have developed it during pregnancy and now have started to accrue the effects of it. So very important. Sometimes hypertension goes away after your gestational period. Sometimes it lingers and becomes chronic hypertension. So it's very important somebody is keeping an eye on that. When your heart has responded that way one time to stress, the chances are in the future, other stresses can cause the same effect. So what I tell people is, it's important from a preventive perspective to keep an eye on this. It doesn't mean that you can't have a future pregnancy. Not at all. Absolutely not. If this is all managed, it can be done very safely. It does not mean that you get a heart attack in 10 years or anything like that. No, it just means that it's something that needs to be kept an eye on. It's not something to forget, to leave to the wayside. Oh, this was a problem during my pregnancy and I can just forget about it. So whether it be your primary care or with a cardiologist, I do recommend follow-up and making sure that you are not accruing any other risk factors. So making sure you're checking your cholesterol, making sure we're We know about your weight, your waist circumference, and all of that is under control, so you don't add any more risk. Does that hopefully answers that question?
Perfect. And we have another, as long as we're taking a pause. How much is long-term oral contraceptive use a risk factor for later heart problems?
So I think I have a point on this coming soon, but it has not actually been tied to causing later heart problems unless you also have certain other risk factors. I think it's 2 points down here, right? So in women, if you look at the last point here, in women who have a history of smoking, migraines with aura, or blood clots, we have found that there is an association with causing both problems while you're on oral contraceptives. So even as a young person, you increase your risk of having blood clots, you increase your risk of having heart issues. Over time, though, oral contraceptive, if used during your reproductive years, doesn't accrue risk to your heart. It's not protective in any way, but it doesn't cause risk to your heart because most of the oral contraceptive regimens are built to be a little bit in sync with what your normal natural hormonal production is going to be through each cycle. So, and there hasn't been a link found as such in any data that oral contraceptive use during a young age predisposes you to heart disease later.
Thank you.
And the other point that I wanted to make with hormones in the heart is that the main role really is to help women with postmenopausal symptoms. And just to drill this point a little bit more, when you're talking about perimenopausal symptoms, we're talking about hot flashes, we're talking about fatigue, we're talking about tiredness, all of those kind of things that women deal with during the perimenopausal period. We find that the most effective time to take hormonal therapy is during that sort of perimenopausal period, the few years of that time. Once those few years pass, you will actually not accrue benefit anymore from the hormonal therapy because your receptors sort of die down and remodel completely in the body. But at the same time, if you continue the hormonal therapy beyond those first few years, there is some small data that says it increases your risk of heart disease. So the key point here is you can take hormonal therapy for the duration of perimenopausal period, but it is not recommended to be taken for a very long term. So taking it for 10 years, 5 to 10 years, up to 5 years is what the general recommendations now are. Beyond that, it is questionable. So that's where the use with caution label comes. Okay, so that's kind of what I wanted to talk about for hormones in the heart in women. Moving on to hormones in the heart in men. So to be fair, since we did say her heart versus his heart, I thought I should bring this up too. So in men, the important thing to remember is a diagnosis of low testosterone requires both symptoms and consistently low blood levels. So what this entails is having the symptoms of fatigue, having the symptoms of low energy that come with low testosterone levels and aging have to accompany measurements of testosterone levels being low. Just having one or the other is not sufficient to start treating somebody on testosterone because you can have fatigue and low energy even as you just age normally. Or if it is very sudden and unusual, then you should be getting looked at to look for whether you have cardiac disease, whether you have pulmonary disease. But the solution isn't let's treat all tiredness or low energy with testosterone. You have to have a combination of the two things, the labs and the symptoms. And the reason I drive this home is because it is not recommended to improve heart health. If you take testosterone when you have normal testosterone levels, what happens is that you kind of amplify that effect quite a bit. And that has been shown to be a little harsh on the heart. So that is what we try to avoid by telling people that you should take testosterone supplementation only if you do, in fact, have a deficiency. In patients with confirmed testosterone deficiency, replacement did not increase the risk of heart attack, stroke, or cardiovascular death compared with placebo over a period of 2 years. This is, I think, the most recent data that basically says that in those people who have symptoms and who have low levels, when they did testosterone replacement for up to 2 years, there wasn't an increase in heart disease. So the key is, as long as you're being appropriately treated, you should not increase risk of having heart disease. But if you are inappropriately taking testosterone, you're not supposed to be, then you're in murkier waters, and then this data wouldn't stand. Okay. So the last bit of my talk is going to focus a lot more on how we can all stay healthy. So we're gonna try to get some key factors in that are relevant to both men and women in terms of, what are the key takeaways, key important things that everybody should be doing to try to maintain their heart health. So I'll pause again. If there are any questions regarding anything else, please let me know, and then we can move on to this.
Dr. Hussain, there is a question in the Q&A regarding a high calcium score of just above 800. Could you address whether that is considered high and how quickly someone should get in to see their cardiologist?
So it does depend on both age and gender, a calcium score. Now, without asking the discussant what their age is, I don't want to do that. But I would say if you have a calcium score of 800 and you are a person under 50, if you're a male or a female under 50, then definitely get in to see your cardiologist soon. Not necessarily because you have a blockage, but even when you don't have blockage, the presence of calcium is an indication of plaque deposition. And that plaque deposition may not be causing blockage today, but it can cause blockage in 10 years. And what you want to do is you want to be on good preventative therapy. You want to be on statin medication, cholesterol lowering medication, so that you don't let that get out of hand. Now, if it is 800 in somebody that is under, it's over 65, then I would say this isn't something that requires you to see your cardiologist ASAP unless you have symptoms of chest pain or shortness of breath, in which case the calcium score becomes irrelevant. You should be seeing them for symptoms. But if you're over 65, it's more as you age, everybody develops a little bit of plaque. And people who have actually been on statin therapy for a very, very long period of time, we have found have more calcium. And it's not because statins are giving you more plaque. It's because statin stabilizes the vulnerable plaque in your arteries. So there's two kinds of plaques, hard and soft. And the soft plaque is actually responsible sometimes for causing acute heart attacks. And what statins do once you start taking them is it finds all this soft plaque and it stabilizes it. So that can sometimes look a little bit harder and calcified, but it isn't causing blockage. It sort of grows outward of the vessel, so it doesn't cause blockage, but what it does is it tries to stabilize those areas that are at risk. So the score by itself, without the context of whether this is a man or a woman, what the age is a little unhelpful. I would say things to remember is if you have symptoms, don't hesitate to go to a cardiologist. Your calcium score is irrelevant. If you are not on any kind of cholesterol lowering medication, you should see your cardiologist when you can so that you can try to get on it. And, I would say don't check calcium scores repeatedly if you've been on cholesterol lowering medication for a while, because the numbers then don't actually align with your risk very well.
Thank you. And I'll remind everyone on the call that Ascension does offer a calcium score test for $49. So if you are curious about what your calcium score is, we do offer that test here at the hospital, and it's a cash payment of $49.
Thank you for that, Lisa. That's very helpful. So I will say that anybody who is curious about their heart health, who has not started taking cholesterol or isn't convinced cholesterol lowering medication, or isn't convinced that they should be on it or not, for them, I would say a calcium score is very, very useful because you can understand where your risk profile is. We have calculators that can tell you where on the percentile line you are for your age and your gender.
And one other question, are there specific things that a woman should ask her cardiologist that pertain to, what tests specifically they should be running for women versus men?
I wouldn't say that the tests per se are different. I would say that risk profile can be different in women. We are still going to test things with the same standard test. We're going to do echocardiograms, we're going to do calcium scores, CTs, et cetera, et cetera. So it's not a matter of asking your cardiologist, do this test for me because this kind of test is better for women. No, it's nothing like that. I would say that don't be surprised if your cardiologist asks you about your obstetric history. Don't think they're a weirdo. understand that it's because they're trying to understand your risk profile, trying to cater things to you a little bit more. If things come to your mind, if you recollect that, oh yes, I did have high blood pressure during my pregnancy, or I did have diabetes, or I do have lupus, I do have this other autoimmune disease, definitely be forthright and let your cardiologist know those things, because they will help them cater your risk profile, customize your therapy a little bit more for you. Let them know about your family history always. If there's family members who've had heart arrhythmias or valve problems or coronary artery disease at a young age, those things are very useful for both men and women, because they give a sense they paint a picture of your genetic profile as well.
Great. And then there are a couple more questions. Someone was diagnosed recently with type 1 diabetes and wants to know what can be done now to prevent heart issues in the future.
So the key for somebody who has just been diagnosed with type 1 diabetes is making sure they are getting their A1C to below 6. Diabetes is linked with heart disease, with kidney disease, with stroke, with peripheral artery disease. But we have found that if you manage to maintain your blood sugar levels at normal levels, it'll most often be with insulin along with some other adjuvant medications for a type 1 diabetic, then that risk is the same as the general population. The problem occurs is if, as a type 1 diabetic, if you're not able to maintain your blood sugars, that's where your risk gets higher and higher. I would say that if for some reason it is troublesome to maintain your blood glucose level, then you should be somebody who gets screened for high cholesterol. You should regardless be screened for high cholesterol levels, and make sure that you are being appropriately treated for that. So cholesterol lowering therapy, if you're put on a statin medication, definitely very, very recommended in type 1 diabetics. Sometimes, based on your risk profile, they might also ask you to be on a baby aspirin. That is fairly common and completely guideline directed and evidence-based benefit. There is a small subset of people with diabetes, particularly type 1 diabetics, who don't have the typical chest pressure symptoms with heart attacks. So we do warn you and we do caution you that if you do have symptoms that just don't feel right, if you have episodes of sweating, or if you have nausea, vomiting, have a lower threshold to go to your doctor or go to the ER, especially if your blood glucose is not well controlled. Okay.
Thank you. And a couple more. How often should a person have a cardiac calcium test? Is once enough, or is there a cadence that someone should adhere to?
That's a really interesting and great question, and one that we have sort of answered in the last couple of years. So as I would say, getting your first calcium score is totally acceptable. Everybody can get a first calcium score. If it is 0, which means there's no calcium, it is okay to actually repeat it in a few years down the road and see where you land again. If it is not 0, there actually isn't a whole lot of benefit to repeating the test, because presumably if your calcium score is not 0, you already have plaque and your doctor will already recommend putting you on some kind of cholesterol lowering medication. And like I said, once you're on cholesterol lowering medication, it stabilizes plaque to the point where it makes your calcium score look a little higher than it originally was. So the interpretation is very muddy for us, comparing somebody that gets a calcium score for the first time and then gets put on cholesterol lowering medication. And then afterwards, we're trying to look at it and we're like, oh, how much of this is because of cholesterol medication? How much of this is because of them just progressing in their disease state? If you have a very low calcium score and you opted not to take cholesterol lowering medication for some reason, it's again worth repeating a calcium score in some period of time. If there isn't really any guidelines of when you should do it, but I would say if you're a 0, you could probably hold off for about 5 years before you repeat another one.
Okay, thank you. And are there any preferred cholesterol medications these days? I know they come in and out of favor, new ones come along. Can you talk a little bit about what the most effective cholesterol medications are currently?
I would say that as much bad press as statin therapy gets, statins are actually still the first line medication for cholesterol lowering. And They have a very storied history in being extremely effective. They've been around for decades. And we know for a fact that they definitely lower your cholesterol. Will they get them all the way down to the levels we want you to be, depending on what your risk profile and your needs are? Not always, sometimes, but not always. And then we have adjuvant medications that go along with it. So another medication that I often add on for my patients is ezetimibe, or the often also called Zetia. It is actually a very good conjunct. It works very well with statin therapy. By itself, it is a weaker cholesterol medication, so I don't typically give it to people just like that. If there's somebody who has been tried on one kind of statin therapy, had some kind of side effects, typically I try them on at least 1 to 2 more different statins, because there's about 4 or 5 of them out there that are in use. I typically try them on a second or a third drug and see if they can tolerate that, or work with the doses or make some adjustments and see if they can tolerate that before I move on to try the newer lipid lowering therapies. Because one of the things with the newer lipid lowering therapies is they're very good at lowering the cholesterol, but most of them are in injectable form. So that can be a little inconvenient for people. And we do still run into issues with insurance, because insurance companies do want us to really prove that the patient cannot tolerate statins, which are the first line and best drugs available, before you move on to the second line therapies. So that's what I tell people, that we can try the fancy schmancies, but there is something that has been around for a very long time that's very good. And if we can figure out a way that you tolerate this with either dose or regimen or some kind of combination of the two, or trying out a different statin, then I would love to stick with that.
Okay, and here's kind of a broader question. If heart disease runs in your family, what tests should you ask your healthcare provider about to better understand your own risk?
Um, it depends also on what kind of heart disease is, but assuming that we're talking about coronary artery disease, heart attacks, history of family members having bypass grafts, and or stents at a young age. And when I say young age, we're talking about less than 65. So if you do have family members like that, parents and siblings who've had that kind of history, what you want to make sure first is, for yourself, you want to know if you have any kind of symptoms of chest pain or shortness of breath or dizziness, something that would trigger further testing so that they can look for whether you have any of those things. That's the first thing you should think about. So have a lower threshold to present to a doctor if you have symptoms. That's the first thing. And the second thing is, make sure, and this doesn't have to be with a cardiologist, this can be very well with your primary care doctor, make sure that at least once in your lifetime, as early as you can, get a lipid panel checked. Check your cholesterol, look at the numbers, sit with your PCP and understand whether these numbers are good or whether they increase your risk of having coronary disease in the future. And it's not a one-time check, it is a yearly check, because if you have genetic tendency, if you have some kind of familial tendency to have premature coronary artery disease, you can manifest at any time. It's not that if your cholesterol is fine when you were 20, it's going to be fine when you were 30 or fine when you're 40. So it's something that needs to be checked every year and then needs to be understood and followed and treated if it's elevated.
Okay, thank you. That was a lot of questions. We'll let you move along a little bit and we'll come back to some more.
No, that's great. It definitely goes along with my theme of the last bit of this, which is how can we all try to stay healthy? And these are just daily practices that we can all do to improve our heart health. So know your numbers. This is kind of what I've been saying for the last 5 minutes already, but know all your numbers. Know what your blood pressure is like. Know what your cholesterol is like. Know your blood sugar. Know your weight and your waist circumference, and work on all of these. So when I say know what your blood pressure is, I say that if you have a history of high blood pressure, it isn't enough to just every time you go to the doctor, which is once in 3 to 6 months, you get that one blood pressure check and it's enough. Now, if you have high blood pressure, if you're already being treated with it, you should be checking your blood pressure through the month by yourself, and ideally making a little log so you can show it to your doctor later on. It doesn't have to be every day. It doesn't have to be obsessive. Even if it is being done a few times a week, a few times a month, depending on whether you tend to run more normal or tend to run a little bit on the higher side, it does help paint a picture for your doctor when they see you in the office. Because what they get, that one blood pressure, it's just a snapshot. We don't want to treat just a snapshot. We want to treat the whole picture, right? The same thing goes with cholesterol, as I've been sort of hammering home the point. Make sure that you get your cholesterol checked and check it every year. Blood sugar, same thing. Your blood sugar, and these days, even your A1C. I think almost all PCPs check it every year, so definitely keep an eye on that. Your weight and your waist circumference, definitely something that all of us try to understand and do a better job with, of maintaining our weight at a certain level. And waist circumference. The reason I say waist circumference is important is because we found that body types with larger waist circumferences tend to have more adipose tissue deposition in the stomach area, which increases your risk quite a bit of heart disease. So that's an important thing. So it's not just what your overall weight is, but also the distribution of your weight. So moving on to the next point, which is movement is medicine. And some of you are fans of Finding Dory, then she says, just keep swimming, right? So I kind of tell people, just keep moving. That's how you'll take care of your heart. So if we're really hammering into actual recommendations, it's about 150 minutes of moderate exercise each week. The easy way I tell people to think of this is, if you can walk for 30 minutes 5 days a week at a pace that makes it a little hard for you to talk to the person you're walking with, then you're doing it right. Okay? Everybody may not like walking, but that is just a standard exercise that is good enough cardio to keep your heart well conditioned. You also want to try to add 2 days of strength training. This is especially valuable for women because we have found in multiple studies that doing a little bit of strength training, a few hours a week, actually makes a ton of difference when you're approaching your perimenopausal years. It actually reduces the chances of you having a lot of symptoms or a lot of fatigue, having more muscle mass on you. Okay, so this is actually more a point. Men can do strength training, but women might benefit from it in their perimenopausal years. And most importantly, the best exercise is the one you'll keep doing. So if you like to swim like Dory, do that. If you like to walk, do that. If you like to go to the gym, do that. If you don't like going to the gym and you like walking outside, which can be rough in the winters, but do what works for you. That's the most important thing here. Give your heart a good night's rest. This is important. People really undermine the value of sleep, but it is very important. Trying to get 7 to 9 hours of quality sleep each night is very important. And the reason is, this is a reset for your entire body. When you're asleep, your heart actually goes down to the heart rate and the level, which is your basal metabolic rate. So it doesn't, if your heart runs fast or is pumping really hard, or you have high blood pressure through the day, that all of those things tend to actually taper down when you're asleep. So the more hours you get at night of good sleep that's not disturbed, the better it is. Poor sleep increases your risk of high blood pressure, diabetes, obesity, and heart disease. And this brings me to untreated sleep apnea, which can cause heart arrhythmias and also can eventually create high pressure systems inside of the heart. So if you get a diagnosis of sleep apnea, and sometimes it happens because you have a partner who tells you snore, or sometimes it's because you notice you're extremely tired through the day and you're just having these moments where you just fall asleep while you're at your desk or something like that. If you get diagnosed with sleep apnea, definitely do work with a sleep specialist to figure out whether you should be on a CPAP or whether you would benefit from some other kind of therapy. I know a lot of people say, oh, they told me to take a CPAP years ago and it's real troublesome to use it and I just can't do it. But there's actually a lot of evolution in the treatment for sleep apnea. So I would definitely encourage you to speak with your sleep specialist or your pulmonologist and figure out what's the right thing for you, because there's a lot of customized treatment these days for sleep apnea that definitely take advantage of, because sleep apnea is related to heart arrhythmias, atrial fibrillation most commonly. And for anybody who smokes, take the smoke break forever. Smoking remains the strongest preventable cause of heart disease. Anybody with any kind of history of smoking tends to have a somewhat increased risk of having coronary disease, something to keep in mind, okay? Quitting reduces your risk almost immediately, and the benefits continue to increase over time. Studies have shown that ballpark of about 15 years post-smoking, all of your organs start to behave like that of the general population, so your risk becomes sort of similar. That being said, that's, I think, more for the lungs, but for the heart, it is still, if you have a very long history of smoking, you are still at a higher risk of heart problems. So always keep that in mind and definitely mention that to your doc, who can then immediately talk to you about quitting. Avoid exposure to secondhand smoke. If you do have that kind of exposure, that's something to mention too. So it's not enough always to say that, yes, I don't smoke, or I've never smoked, or I've smoked 1 or 2 cigarettes. But if you're exposed to it frequently from other people in your life, in your household, at work, it's a good thing to mention that it does increase your risk. And it's never too late to quit. Doesn't matter how old you are. Doesn't matter if you've already had heart disease. Doesn't matter if you already have stents or you have lung disease. If you quit, you start to get the benefit of that right away. Okay. And when your heart speaks, act early. So this is something that I touched upon earlier, but see your provider regularly if you have high blood pressure, diabetes, high cholesterol, and family history. So these are the ways that you can keep an eye on things closely, be followed closely for these issues, and seek immediate attention for chest discomfort, unexplained shortness of breath, fainting, new or persistent heart palpitations. Okay, so these are the symptoms I tell people to keep in mind. But if you have any of the risk factors we talked about, high cholesterol, diabetes, don't hesitate if you suddenly start to get strange sweating episodes or strange dizziness or nausea and vomiting. Have a lower threshold to see somebody about it. Okay. That brings me to our last takeaway. While women and men may experience heart disease differently, the foundations of prevention are very similar and benefit everyone. Thank you all for your attention. I'm happy to take any more questions that you all have.
Well, thank you so much, Dr. Hussain. We do have a few more questions. I'll try to paraphrase because a couple of them are a little lengthy. What effect does a low potassium count have on the heart?
The most common thing I tell somebody that chronically runs with a low potassium, and usually this happens with some kind of endocrinological issue, or if you're on medication that is lowering your potassium for some reason. But what I will say is it slightly increases your risk of having heart rhythm abnormalities. So if you run lower, if you're on medicine that causes you to run on the lower side from your potassium perspective, I would say you should be on some kind of supplementation just to make sure you're above 3.5 at all times. And this reduces your risk of having heart rhythm abnormalities because potassium really is linked the most to, for the heart per se, is linked the most to the electricity of the heart.
Thank you. Another question is, for someone that has had an adverse reaction to statins and is trying to control it with like a Mediterranean diet, and weight loss and exercise, and the numbers really still aren't budging, would you suggest something like plant sterols or any type of sterols?
So, unfortunately, there is not much in the way of data for plant sterols. These are not drugs that go through, these are not medications or substances that go through the extensive trials that a lot of the medications, the allopathic medications we distribute are. So they both don't have the strength of evidence as well as the stringent oversight when they're made to make sure that they're all uniform, they're all the same, that there aren't any strange additives there that could cause other issues. So I tell patients if they can avoid these kinds of things, plant sterols, what have you, that's better. To answer your question about you've been on a statin, it didn't suit you, you've tried your level best and done a great job with diet, exercise, weight loss, what should you do if your cholesterol is not coming down? So the thing is, even after doing all of those things, sticking to a great diet, doing great exercise, maintaining a good weight, there is a genetic component that we have more and more in the more recent years realized is very closely linked to high cholesterol. Unfortunately, none of us can change our genes. So when you get to that point where you have done everything from a lifestyle perspective and your cholesterol is still running high, that's when you and your provider have to understand that there is a genetic component here, something in your, and it doesn't necessarily mean that your mom or your dad had high cholesterol. It just means that maybe you have an innate native mutation that's causing you to run a little bit on the higher side and, or very much on the higher side, depending on what your cholesterol is. And you definitely need therapy. So I would say if you haven't done well on a statin, you could first try an alternative statin because there's about 4 or 5 of them and see if that works. You could try options like taking it every other day, taking it at night, especially if muscle aches is the most common symptoms. I see that Sometimes, again, the data for this is a little bit murky, but sometimes taking the statin with a CoQ10, which is an over-the-counter medications, helps some people tolerate a little bit better. If all of that fails, then talk to your provider about doing different cholesterol medication. There are alternatives. There are PCSK9 inhibitors. There are other sRNA inhibitors that are out there now, newer medications that are actually meant for people who really, really can't tolerate statins.
Thank you. Any particular symptoms to be alert to if one has a natural aortic valve replacement that would indicate the valve is deteriorating?
The question is any symptoms to pay attention to
After having a natural aortic valve replacement, would there be any symptoms that would indicate that the valve is deteriorating?
That's a great question. So one thing that to keep in mind is when did you get your valve replacement? So typically we tell people when you do get, I'm assuming from the natural aortic valve replacement, we're talking about probably a bioprosthetic valve, which is usually a pig valve or a cow valve. And those typically, not for everybody, not necessarily, but typically they roughly last about 10 years. We've seen it last longer, 15, even 20 years sometimes. We've seen it last for a shorter period of time, depending on other aspects of your heart, other loading conditions, so on and so forth. But the symptoms to keep in mind are the most common thing that you will notice if your valve starts to deteriorate is shortness of breath. That's one of the first things that comes. And it's usually an insidious thing. It's not that one day you were fine and the next day when you climb the stairs, you're short of breath. It's a thing that develops slowly. You start to notice that you're more tired. Previous levels of exercise that you were doing or activity that you were doing just is harder and harder and harder to do, and you don't really have a great explanation for it. A lot of people tend to just link this to normal aging. But I would say if you're somebody that does have a previous valve replacement, have a higher index to go see somebody, to go see your cardiologist, or bring it up with your cardiologist if you notice a shift in your activity levels. And this is why I tell people to try to be as active as you can, because if you are an active individual, you will notice the change sooner than if you're somebody that doesn't get out much, doesn't do much, is more sedentary. You will notice the changes later when it's kind of late in the stage of things. The other thing would be lower leg swelling that you can look out for, but typically the tiredness and the shortness of breath precedes leg swelling.
Thank you. What is the best diet for a healthy heart? I know that's probably controversial, but
Yeah, it is controversial in the sense that there is some data, but there isn't the data isn't all encompassing. It's not as though we have gone through every single diet that's out there, every cultural difference, every cooking difference, and been able to prove that one thing is better than the other. You will often hear the Mediterranean diet is considered very good, and that's because there were very dedicated studies done for this, and it kind of makes common sense as well. So the Mediterranean diet typically involves lean meat and proteins. We're talking a lot of chicken, a lot of fish, obviously in moderate amounts, a lot of green leafy vegetables, nuts, whole grains, low-fat yogurt. So all of these things, very good in general. If you think about it intuitively, also, it makes sense, right? Avoid greasy food. Don't fry your food. When you cook your meat, bake it, grill it, broil it. Do not fry it, right? So all of the things that intuitively make sense also are the best diet. Obviously, I will not ask everybody in the world that needs to shift to a Mediterranean diet to maintain their heart health. But I would say if you like certain things that you know are a little on the higher cholesterol side, just eat it in moderation. That's the important key takeaway. Avoid things with a lot of sugar. So when you're having soda, if you're the kind of person that when you have a pizza, you need to have a soda, go for the diet version of it so that you're not just having, you know, a lot of sugar content added to your meal in addition to what you've already eaten. So, and for those people who are interested in plant-based diet, there is data also that plant-based diets are really, really good for heart health, and that's just because we take away a lot of the saturated fats that come with meat. But again, there is no perfect diet. I would say try to eat food that you cook more, add less salt, and things that intuitively make sense, like not frying your food and trying to go for grilling and baking and broiling when you're using your cooking meat are just practices that are better in your diet.
thank you. And another question back to side effects from statins. Do you suggest CoQ10? And if so, is there like a typical dosage that you would recommend for patients to feel relief from the side effects?
So again, I do say that I've seen patients have some relief, but it is honestly not very well tested data-wise. I've seen anecdotally 50-50%. So 50% of people feel good with it, 50% don't. There is some enzyme mechanics that people suggest are the reason that coenzyme Q works. The over-the-counter versions are perfectly fine. You would take them the same day, the same time as you take your statin. But don't be disheartened if it doesn't work, because it doesn't work for half the people, if not more. And it is unclear even why it works for just half the people and why it doesn't. So it's something to try, and if it doesn't work, it doesn't work. You don't tolerate the statin. You try to work with your provider to do a different kind of statin, and if that doesn't work, then you can look into other lipid-lowering therapies.
Thank you. Should you have an EKG every year, or starting at a certain age, should you have one every year? Can you just speak to that for a moment?
I think having one EKG when you see your primary care as an adult is a good idea. If you have a completely normal EKG, save for a situation where you develop symptoms, or we are questioning rhythm abnormalities, or you had an episode where you passed out, or you have developed chest pain or shortness of breath or some kind of symptoms, there is no role to do an EKG every year. So it's really meant for people who already have an abnormal EKG and you're trying to understand something further about it. So it's at that point, you're probably treating something if you're getting an EKG frequently. The other scenario where we get an EKG almost routinely is if you're about to get surgery and you have, per the surgeon's um, assessment, that you do need some kind of cardiac assessment. It may just be because of risk factors, it may be because of your age. Then we typically do always get an EKG just to make sure at a baseline you don't have any kind of abnormalities that would suggest you may not tolerate the surgery well. So those are the situations where even without symptoms you would get an EKG. But getting one makes sense. Getting them regularly is only meant for if something is abnormal or if there's a reason for it or you have symptoms. But not once a year. Not everybody needs a once a year EKG.
Great. Thank you so much. I think we have time for one more question. If a person has borderline cholesterol, high cholesterol, high blood pressure, and blood sugar, and wants to avoid taking heart medications, can those things be managed with lifestyle changes if there's also a family history of heart disease, or should they really take that step to medicating what needs to be moderated?
I would say if we're talking about borderline, I would say I'm assuming you're meaning borderline cholesterol levels, prediabetes, that kind of thing. If you already have
Correct.
a condition, if you already have been diagnosed with diabetes, or if you've already been diagnosed with very high cholesterol, you should do the lifestyle adjustments because they go hand in hand with the medications. Get treated in that situation. But if your everything is borderline, then I definitely do think there is value in first trying lifestyle modifications. And typically, if people are adamant to start taking medications, I say, all right, let's start doing something. Let's have some goals set for your 3 months and 6 months to see where you are in your weight, where you are in your sugar, where you are in your cholesterol after you make all of these lifestyle adjustments, be them diet or weight loss or exercise levels, and reassess. And if you're able to bring things down from that borderline into normal range, that's perfectly good. You don't need to necessarily be on medications, or at least not at that time. You can at least postpone being on medications. But if you've already kind of crossed over from that borderline into the actual abnormal range, then it warrants probably being on medications.
Well, thank you so much for presenting today, Dr. Hussain. So many great takeaways for everybody. We really do appreciate you sharing your expertise. If you'd like additional information about the services offered at Alexian Brothers, or to make an appointment with Dr. Hussain or any of our providers, you can scan the QR code and it'll bring you to our provider page. And I think there might be one more slide, or was that the last one? Oh yeah, here we go. And you could also scan either of these QR codes. So thank you so much, everybody, and enjoy the rest of your evening.
Thank you all. Thank you so much for taking the time out to join, and hope everyone benefited from this.